بس بدأ. ايوه بدأ.
بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله الكريم. السلام عليكم ورحمة الله وبركاته. First, I would like to thank Khartoum Medical Student Association for this invitation. And today we'll deliver the lecture about interventional radiology. And I will concentrate to show you cases from Sudan here during the last 10 years. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. First, we can define interventional radiology. This is a new exciting subspecialty from radiology, and in this specialty, also specialty, we can use advanced imaging to solve big problems, big medical problems. So with minimally invasive technique, we can solve big problems in medical situations, like brain hemorrhage, peripheral vascular disease, and others. And there is wide spectrum of interventional radiology. We use these minimally invasive procedures to treat different areas in neuro. There is neuro interventional procedures, and we use interventional radiology to treat peripheral vascular disease and to treat some problems in gastroenterology conditions, also in obstetric, urology, chest, and other systems in the body. And this is the ideal interventional radiology suite. We need inside very advanced angio machine, and anesthetic machine should be there, ultrasound, trained staff, radiation protection devices. As we know, the cath lab and angio machine give harmful radiation for the staff working inside. And this is one of the interventional radiology suite here. We see this is the cath lab, this is the patient here, this is anesthetic machine, ultrasound, and this is the stop-locker and wave-trained personnel should be there. And as we said, interventional radiology now is subspecialty from radiology, but still now it's subdivided into different subspecialty. Now there is some doctors doing only neurovascular intervention, and another specialty they do body intervention in the vascular to treat peripheral vascular disease and others. And there is oncology intervention also. People specialize in this different specialty. And now we will talk in details for these procedures. This is the main procedures constitute the interventional radiology specialty. In interventional radiology, there is embolization. We will talk in details how to do embolization, definition of embolization. We deliver cases here, and we also want to know the indication of embolization. Another big title is thrombolysis. Also, we'll show cases in this title. Stenting, treatment of stroke, either, as we know, there is hemorrhagic stroke or ischemic stroke, and there is others procedures we can talk about them. Embolization. The terminology reflecting minimally invasive procedure used to occlude unwanted vascular abnormality by using embolizing material delivered through small catheters. Vascular abnormality involve vascular malformation, aneurysmal dilatation, vascular masses. We can use embolization and embolic material to occlude and to solve and to treat these vascular abnormalities. This material usually we need it to do this procedure, guiding catheters, microcatheters with detachable tips, embolizing material. And embolizing material, this material used to occlude vascular abnormality, to occlude the vascular bed of vascular masses, to cut the connection between the arterial feeders and the venous drainage in vascular malformation, arteriovenous malformation, and to treat and to embolize aneurysm, which sometimes making severe bleeding, threatening patient life. And here we have solid embolizing material like coils, BPA, laser, web, sphere, and others. Also, we have solid and liquid embolizing material. This is used in certain cases like glue, onyx, gel foam, and this is the indication of, or this is the condition that can be treated by embolization. As I said, vascular lesions, this is like arteriovenous malformation, arteriovenous fistula, aneurysm, and we will go for detail this condition, and we'll give sampling cases for these vascular lesions. Also, we use embolization to control bleeding and also to treat benign vascular tumor like fibroid, benign prostatic hyperplasia, hemangiomas, angiomyolipoma of the kidneys, germ cell tumors, juvenile angiofibroma, globus tumor, and also to treat some malignant vascular tumors like HCC, renal cell carcinoma beyond surgery, vascular mets from RCC, and from thyroid. So we'll start with the first item, control of bleeding. And as we know, bleeding is emergency problems, life-threatening condition. And we know bleeding can be leaking of blood outside the normal vascular tubes. And some people can be related with upper GI bleeding, and upper GI bleeding can be divided into variceal or non-variceal GI bleeding, also upper and lower GI bleeding. And also we use embolization to control postpartum hemorrhage, bleeding after delivery, and post-menopausal bleeding also. And epistaxis also can use embolization to control epistaxis, to secure aneurysm in subarachnoid hemorrhage, to secure and to occlude the bleeder site in the chest, in the lung, patients that presented with hemoptysis, also to occlude the bleeder site from the kidneys and the urinary system. So we'll divide, we'll go one by one to the system, and we'll start with brain hemorrhage. We know brain hemorrhage, there is different types of brain hemorrhage: subarachnoid hemorrhage, epidural, subdural, intraventricular hemorrhage, intracerebral hemorrhage. And here, some type of brain hemorrhage can be treated directly by bare hole, by shunting in interventricular hemorrhage, but in subarachnoid hemorrhage and intraventricular and intracerebral hemorrhage, sometimes there is underlying lesions, vascular lesion, causing these problems and should be treated by intervention procedures. I will show you this is short film.
Endovascular coiling or endovascular embolization is a minimally invasive technique performed to treat brain aneurysms. The goal of the treatment is to block blood flow into the aneurysm and therefore reduce the
We show
risk
here
of aneurysm
technique.
action.
How can
In
we
this
use?
procedure, a catheter connected by a wire is inserted through the femoral artery of the groin
You
until
can
the
be access
bottom
to the
of
common
the
femoral
affected
artery,
artery.
and we can reach through this pathway to the brain
The blood wire is removed.
arteries.
The catheter carrying a solid cotton
And
coil
we can
is
treat.
introduced inside the initial catheter and is navigated
This is
into
an
the
aneurysm,
opening.
usually causing
The
some
coil is
hemorrhage,
then
and
carried into the
we
aneurysm
coil
site.
it
A small
using
electrical
microcatheters,
is passed
putting
through
inside the
the
aneurysm.
catheter. It will take several coils to fill the aneurysm. The coils induce blood clotting inside the aneurysm and seal it off from the artery. In some cases, in the event that the aneurysm is too wide, a stent can be used to keep the coils within the aneurysm sac. Stent-assisted coiling involves permanently placing a stent in the artery prior to coiling. The stent acts as a scaffold inside the artery to hold the coils in place.
Yeah, just to show you how can we access the brain arteries and to solve problem there, we actually access all our procedure from the common femoral artery, and we go through using microcatheters, guiding catheters, wires, and other material to reach the lesion there in the brain, and we coil it to secure and to prevent rebleeding from this lesion. As I said, one type of brain hemorrhage is subarachnoid hemorrhage, which is, subarachnoid hemorrhage. Yes, it is a very serious, life-threatening condition. The patient usually presented with severe headache, vomiting, and signs and symptoms of increased intracranial pressure. And patient actually will arrive ER with these symptoms. Should be go directly for CT to know where the cause and the underlying cause of this severe headache and these severe symptoms. And actually, this is a CT of a patient with presented with severe headache, and we see here the hyperdense area in basal cistern and the Sylvian fissure. This indicates that there is subarachnoid hemorrhage. This is hemorrhage in the subarachnoid space. So such cases usually we go and to do more investigation to know the underlying cause of these problems. So in this case, this is another case with subarachnoid patient presented with severe headache, and we do CT for this patient, and we see here in the Sylvian fissure there is subarachnoid hemorrhage extended into intracerebral part, and in such cases we go directly to survey the brain arteries and brain vessels to know the underlying lesion there. And here this is a CTA of this same patient. We find here the outpouching lesion from the artery. Here this is the internal carotid artery divided into middle cerebral artery and anterior cerebral artery. This is A1 and the vertical is A2, and this is the middle cerebral artery. We see here a lesion coming out from middle cerebral artery, and so this is aneurysm. This is abnormal lesions, outpouching of the internal layer of the artery outside, and weak blood go inside and increasing size and tension inside this aneurysm with fragile wall, and then leaking of blood causing this subarachnoid hemorrhage here in the Sylvian part, and such cases we want to treat this aneurysm and to occlude it to prevent rebleeding again. So here we go with catheter. As you see in the previous video, we go from the common femoral artery and we reach the internal carotid artery here. And here our catheter is the internal carotid artery, left internal carotid artery. And we give this angiography image through the catheter. And we see here, this is the lesion here. This is the aneurysm with protruded daughter sac. This is the rupture side here. If you do not go and occlude this part of the aneurysm, rebleeding will occur and 80% of patients will die if you do not secure this aneurysm. So here we go, and here we secure the aneurysm. This is hyperdense, bright, white coils. Put it inside the aneurysm, and the aneurysm then total occlusion obtained and isolated from the circulation, and then prevent the patient from to develop rebleeding. Aneurysm can occur in the midcerebral artery, anterior communicating artery aneurysm, parathalamic, anterior choroidal, cavernous aneurysm, pericolloidal aneurysm, can occur anywhere in the different arteries of the brain. I will give you another example. Here, another patient with aneurysm here. This is posterior communicating aneurysm. And we see here, this is the posterior communicating artery connecting the anterior circulation with posterior circulation of the brain. And here the groin aneurysm. And this actually patient 4 years ago presented with severe headache, and we did for her CTA and angiogram revealed posterior communicating aneurysm. At the acute onset, we did for her partial coiling to prevent rebleeding because there is wide neck aneurysm. And here we did partial coil. And then after 3 months, we go and put a stent to treat the rest of the aneurysm. And here, this is a stent here, taking the size and shape of the artery, and so it prevents blood to go inside the aneurysm, and then total occlusion obtained. In such cases, usually patient presented with signs and symptoms of subarachnoid hemorrhage, and actually, in certain cases, the aneurysm will be elongated posteriorly and give pressure effect over the third nerve, causing ptosis and third nerve pulse. This is the same patient presented with this posterior communicating artery aneurysm and ptosis. So here we see the ptosis here and deviation of the eyeball on the lateral side and dropping of the upper eyelid. And this is after the procedure, everything done, and the eye returned to normal. Another example, we see example from midcerebral artery aneurysm, and the second one, posterior communicating artery aneurysm, and the last one, the last example is anterior communicating artery aneurysm. Anterior communicating artery, we know this is anatomy. This is the internal carotid artery, left side. This is the right side. In between, there is communicating artery, communicating the right and left carotid arteries. And as this connection, usually this is common side to develop aneurysm. And there is here, this is the MRA showing us aneurysm at the side of communicating artery. And actually, this is the subarachnoid hemorrhage of this apical aneurysm. And here, this is the same. This is the angiogram. Show us the anterior communicating artery, and this is after coiling and securing the aneurysm. Also, one of the causes of brain hemorrhage is ruptured arteriovenous malformation. Ruptured arteriovenous malformation. Arteriovenous malformation is a congenital anomaly usually, and this condition occurring in young people. And some people presented with convulsion and increased intracranial pressure, and some people presented with intracerebral hemorrhage. In this case, the patient presented with posterior intracerebral hemorrhage and intraventricular hemorrhage. And this is the hemorrhage here. And we did for him workup, and we find here there is arteriovenous malformation. This is the posterior cerebral artery from the basilar artery connected to the vein. This is the vein, and this is the artery, and this is the dysplastic vascular area. And here the block coming from this high tension area, because the pressure in the arterial system is very high, going directly, escaping the brain tissues and going direct to the vein. And this will lead to increase the size of the vein, and weakening and weakness of the wall of the vein occur, and leaking can occur from this side, causing this intracerebral hemorrhage, and patient usually presented with severe headache, convulsion, and maybe loss of consciousness. Here we treat such condition also using minimally invasive procedures. We go through the common femoral arteries, the basilar arteries, through the vertebral arteries, and using microcatheter. Using microcatheter, we reach this connection, the connection between the artery and vein here, with this micro connection, with microcatheter, and then we deliver embolizing material, liquid embolizing material like onyx, to cut off the connection between the vein and the artery in this area. And here, this is the last control area. We see here this connection now done after embolization, and this is a very nice smile from this young child. Another patient with ruptured arteriovenous malformation. This is the connection. This is the lesion here, arterial feeders from middle cerebral arteries, and this is the draining vein. And our target to go inside this lesion and to embolize the connection between, not to close the artery and not to close the vein, just to close the dysplastic vascular area. Here we go and smoothly with microcatheter to deliver embolizing material, slowly till you obtain complete occlusion of the lesion. And here, this is the lesion here, and this is after occlusion, total occlusion obtained in this case. Also, we use embolization to control different types of hemorrhage. We can use it to control hemoptysis. As we know, hemoptysis, 90% of patients with massive hemoptysis coming from the bronchial arteries. And here, a patient with past history of tuberculosis, and he developed cavitation and aspergilloma on top of cavitating lesion, and he presented to the ER with massive hemoptysis. And also we go here with microcatheter. This is the bronchial artery, very dysplastic. This is the cause of bleeding, and we go with microcatheter to reach the bleeder side, and we deliver embolizing liquid material here to occlude this side of bleeding, and then hemoptysis stop. Such cases, they passed, they actually, large percentage of them die immediately or solely, because there is the surgical procedures to open the abdomen or to open the thorax. To find the bleeder site is some sort of difficult, or in long term cannot succeed. Also, you use embolization to treat and to control patient with epistaxis. This is the young female patient presented with after trauma with massive epistaxis. We did for her CT angiography. We see here in this phenoid sinus there is hyperdense lesion here. This is a block, and actually also this is ossification of a lesion here inside the left sphenoid sinus here, very obvious. And we did for her angiography, needle subtraction angiography, our catheter here in the right internal carotid artery, and we find here the lesion, and we include it. Actually, this lesion is pseudoaneurysm, and the trauma injured the ophthalmic artery. This is the side of the ophthalmic artery, and ophthalmic artery is injured, and we become pseudoaneurysm. Pseudoaneurysm leaking inside the sphenoid, causing the epistaxis, and here after occlusion and after embolization. Another case, similar case, patient with postpartum hemorrhage, a young lady, also after cesarean section, she developed massive and recurrent continuous bleeding, and with minimally invasive procedure, we go through the common femoral artery. You see here, this is the iliac, this is the internal iliac bilaterally, and this is Allahu Akbar. And this is this is the uterine artery. We go through internal iliac, left iliac, we find the lesion here. This is pseudoaneurysm occurring after cesarean section, the iatrogenic injury to the uterine artery causing this massive bleeding. We go with microcatheter through the uterine artery, and we reach this area, and we embolize it with liquid embolizing material, and this the end of the procedure, and patient recover well. This is minimally invasive procedure, usually done by local anesthesia. Patient is alert. Actually, you can control bleeding in 15 to half an hour without any risk of surgical scarring, surgical suturing, or complications. Another patient, postconjugosal bleeding, the same thing. Another patient with massive hematuria following the iatrogenic injury of the renal artery. Here, this is the pseudoaneurysm, this is the lesion. At the past, the treatment of such condition is nephrectomy, to go and to resect the kidney outside. But after intervention and radiology procedures being there, we go selectively by catheter and microcatheter, and to go for the lesion here selectively, and to just to occlude the problem and to treat the lesions. And here the one branches, and we occlude it here, and the patient recovered well. Another patient also upper GI bleeding, any bleeding more than 500 cc will be circulating bleeding for the patient, and this is most probably arterial source. So this patient with upper GI bleeding more than 500 cc losses, you need to go and to do mesenteric angiogram to go for the inferior mesenteric artery, superior mesenteric artery, celiac, and gastroduodenal artery. And here in this patient presented with massive upper GI bleeding, we go and we go to the gastroduodenal artery here, and we didn't find a lesion here. There is no pseudoaneurysm, there is no leaking, there is no fistula. So we did empirical gastroduodenal artery embolization. This is one of the procedures. If you do not find a lesion here in upper GI bleeding, you can go directly and do empirical gastroduodenal embolization. Here, this is before. It's a gastroduodenal artery, our catheter inside the gastroduodenal artery, and here we include it, and the bleeding stops. Another patient with upper GI bleeding, but in this case, due to pseudoaneurysm, gastroduodenal artery pseudoaneurysm, the result of pancreatitis in a patient, in a Tafour patient. So patient also presented with massive upper GI bleeding. We did for him CT angiography, and we find the bleeder site here. And in such cases, we include such case by sandwiching the lesion here. We put this distal coil here and proximal occlusion. So you, this is the artery here. We go distally, and you occlude the gastroduodenal artery distally and proximally. So you sandwich the aneurysm. Another patient with lower GI bleeding due to angiodysplasia. Here we are in the inferior rectal artery. This is the area of the bleeder side, and we embolize it. Patient recovered well. Another use of embolization to do splenic artery embolization in patient with hypersplenism or in traumatic splenic injury. And actually, if there is arteriovenous malformation, aneurysm, or something like that, you can go by a catheter and you go direct to splenic artery and you embolize the splenic bed of the vascular bed of the spleen, and you glue the spleen by different areas. This is one of the embolization. We can also go through the anal fistula and you embolize the anal fistula. Another, this is also how to control bleeding from injured artery. This patient experienced stab wound and he bled a lot. And this area below the clavicle, if you want to go for surgery, you want to do thoracotomy to find the subclavian artery and to treat this abnormal bleeder side, pseudoaneurysm. But with minimally invasive procedure, you go and we did angiogram for these lesions, and we put a stent. This is the first stent, still there is leaking, and after putting the second step, the lesion here and the bleeding disappeared, and the patient did well. Also, with embolization, we can treat arteriovenous malformation with a patient with arteriovenous malformation in the hand. And here, this is the arterial feeders. This is the splastic arteries and draining veins. We go also by microcatheter to reach the connection between the artery and the veins, and you embolize the lesion. Another example for embolization, really there is a wide range of procedures can be treated by embolization. Benign vascular basis, I will go fast. This is fibroid patient, usually young ladies sometimes experience menorrhagia, presenting with symptoms of menorrhagia, or increasing the size of uterus due to fibroid. As we know, fibroid is vascular benign lesions, and instead of going surgically to remove this fibroid, we can go directly by catheter and wire, and we go to the uterine artery, and then selectively we go to the feeders of the fibroid, and we embolize and occlude the vascular bed of the fibroid, and bleeding and menorrhagia, symptom of menorrhagia will disappear, and also there is reduction in size of the fibroid, and this is suitable procedure and suitable way of treatment for single lady with fibroid and symptoms of menorrhagia and continuous menorrhagia. So you can go bilaterally, you go for the right and for the left uterine artery and to embolize the vascular bed of fibroid. This is a case, we did it 4 years ago, of patient with fibroid. This is the MRI. The patient, she has cervical fibroid here. This is the uterus. This is a very big cervical fibroid, and we did for her embolization because she is single lady. And after embolization, the patient experienced very severe pain, and the fibroid shedding out and go out, and this is the MRI after shedding and expulsion of the fibroid from the cervix. Now she obtain clear cervix and the fibroid canal outside. Also, we use embolization to treat angiomyolipoma. This is a renal artery angiogram, and this is angiomyolipoma. We know it is a benign renal lesions, but with highly vascular areas and pseudoaneurysm. So angiomyolipoma more than 4 centimeters should be embolized or treated because there is high risk to bleed. And if bleeding occurs, usually retroperitoneal bleeding and maybe life-threatening bleeding. Embolization of malignant vascular tumor, hepatocellular carcinoma, renal cell carcinoma, vascular bony tumor. You will go fast. This is a case of HCC embolization. In HCC embolization, we deliver, this is called TAST, transarterial chemoembolization. We treat hepatocellular carcinoma by both. We deliver dextromethorphan and chemotherapy inside the lesion through the arterial way. Instead of systemic chemotherapy, we go by catheter directly to the feeder, to the arterial feeder, to the tumor directly, and we inject the chemotherapy inside the tumor, and then we close the artery. So we cut the blood supply, and we deliver and infuse chemotherapy inside. So this is very, very interesting and type of treatment of hepatocellular carcinoma. This is the CT of the patient before. This is a very big mass, vascular mass, HCC in the left lobe of the liver. And this is after embolization. This is embolizing material after embolization. Another patient, this is a patient with bony mets from renal cell carcinoma. You know, there is pathological fracture, and this patient presenting with severe pain due to increased vascularity in this area. So we go and we embolize the vascular area here, and the pain subsided, and also surgeon can treat this after we embolize the lesions. Another patient with bony lesions. This is bony mets from the follicular thyroid carcinoma, and here it is very vascular, and we embolize it, and then the patient underwent surgical fixation of this pathological fracture. Post-embolization syndrome, patient usually after embolization develops symptoms of fever, vomiting, pain, and can be treated conservatively. Thrombolysis, this is one of our procedures that done in the angio suite, in the interventional radiology suite, and thrombolysis is a procedure now used to treat different situations of embolic and thrombotic events with high incidence of successful rate. Sometimes we know there is ischemia. Ischemia usually can be divided into acute ischemia or chronic ischemia. Ischemia can occur in venous system or arterial system. Arterial ischemia is a very threatening condition. So patient with upper or lower limb ischemia should be treated urgently because we can lose the limb. And we can use now both type of treatment: surgical embolectomy to bring out the clot from the artery and to clear it, or put a catheter inside the clot and deliver tissue plasma activator as a thrombolytic agent to lyse these clots. So this is become fabulous treatment for such condition. Thrombolysis can be useful in many critical conditions, in acute and subacute limb ischemia, upper limb ischemia, also in mesenteric ischemia, massive pulmonary embolism, acute ischemic stroke, extensive DVT, Berchier syndrome, brain venous sinus thrombosis, acute myocardial infarction. All this condition with veno arteriocclusive disease can be treated with thrombolysis. I will give just one example for